more practical element to those principles, we should be seeing all of those components in one form or another, like whether it's person-centered, sort of inclusive, diverse, all those kinds of words should be reflected more specifically in the goals. So I think that ultimately my point around the research is, yes, there are ways to research things that are evidence-based in terms of what works and what doesn't, but also I think there's a lot of need for cultural appropriate work in the space of research and adoption, and so I think that I think that's a gap in this particular goal. We can divide it into two separate ones, but I think it works right now in that goal the way it was written.
This is Rhonda. I'm thinking that really is a priority that goes under this, because we would want culturally appropriate practices to be evidence-based practices. We want to research culturally appropriate practices. So I think making that a priority under this goal actually spells it out.
So just so that I understand, Rhonda, then you are for keeping those words that Hector recommended in here as you see on the screen, or do you instead envision those underneath this goal spelled out as priorities?
I see it as it's written: promote research, identification, and the adoption of evidence-based practices, because we do want new research to create new ones, but then make a priority out of the culturally appropriate.
Okay, got it. We're capturing that now. Thank you.
Wendy, this is Nancy Murray. I think we need to decide, are we going to use the word care recipient or care receiver, so that we're consistent throughout our work?
I agree. What do you all think?
Greg, what do you think has been like kind of the ongoing verbiage for this between recipients and receivers?
I think it's more often recipient.
Yeah.
And we should, I would be fine with that. It's what you see most often, I believe, in the literature.
Yeah. I mean, I think they're pretty much synonyms.
Mm-hmm.
I would say that in my research, in developing things, that caregivers themselves prefer the word care receiver.
Huh.
Okay.
Okay.
Well, then we can throw it open to the group, it's really all up to you all how you want to characterize the care recipient, care receiver.
I think we should use whatever's kind of standard in the industry to make sure that there's no confusion.
Right.
I've only heard recipient.
If there is a standard in that regard.
I don't think there is a standard, because I think it varies depending on your audience.
I've heard more frequently, I've heard recipient over receiver, but that's just.
Yeah, and what I'm saying is that may be true to a broader audience, but not to care receivers themselves. I mean, caregivers themselves.
Are there references in the RAISE Act to the care receivers?
Let's see. I'm not sure that. Well, there is a reference to care recipients. I saw one. I mean, just a very quick read. I saw one as care recipient in the RAISE Act. Because most of the language in here is focused on the caregivers themselves.
I think the issue is consistency more than the words, so I don't go with whatever people believe.
Well, since Greg found the one notation in the RAISE Act for recipient, why don't we use that term now?
Okay.
I agree.
All right, we'll do that. We'll make it recipient, and then, later on down the road as things develop, if we need to, fine tune the terminology, we can always do that.
I'd like to come back to that first bullet. I
Sure.
think you need to leave the word services in there. I'm fine with saying access to programs and
And
services.
services.
Okay.
Mhm,
Yeah, because not all services are part of a program.
exactly.
Nancy, are you okay with swapping out awareness and then deleting outreach and education?
I think we should leave outreach and education because they're two separate things.
So just list them all out: awareness, outreach,
yeah.
education, and access.
Yeah, I would leave them all there for now.
Okay.
Okay.
And they are all measurable.
Yep. Okay.
Regarding that first bullet, I just want to make sure that, and again, I'm just thinking out loud, I want to make sure that this is covered under that, and that is caregivers' access to medical records of the care recipient with, of course, permission from the care recipient. But I just want to make sure that that is in there. Is that covered by services?
So I think last night, and again, we throw this back to you all, I think we were thinking that the reason we listed specifically healthcare in addition to long-term services and supports, we thought it would go in that second bullet, that very point, as a driver and a recommendation. But if you don't feel that, please let us know, or if we need to make it clearer.
I agree with that. That makes sense.
So I have a question around this. So in addition to programs and services, have we, since we're thinking also of the private sector here, it's another word that should be included here is the word product. I'm thinking about, insurance products of all sorts of kinds, from long-term care insurance where appropriate to reverse mortgages for those who are appropriate to take it. So that's one question in that. And then the second one is, when we say health and wellness, do we instead want to just say straight there to optimize the physical, emotional, and financial well-being of caregivers and care receivers?
So if I heard you, Hector, it would be expand awareness, education, outreach, and access to programs, services, and products.
Yes.
Okay. To optimize the health or to optimize the physical, emotional, and financial well-being of caregivers and care recipients?
Yes, that is correct.
I think we were thinking is the financial well-being. We even put that as that third bullet.
Right.
And one thought I have as we go through this exercise is that hopefully as we map out the work to reach these goals, this is Bruce Fink, that as we map out the work to reach these goals, and that's the value of a driver diagram, some of this need to put everything in the final goal sentence will change, right? Once we sort of map out what we mean by this. And so even though this is actually really helpful at this stage because it gets us to consensus around what we actually mean. And what we may find is that it's worth coming back to these goal statements later and where we can edit for clarity, and not feel as that we have to include all the elements. If the elements are in the plan or the priorities in the approach, that'll make clear how we're going to accomplish this.
Great.
This is James Cheeley again. I have a original question to go back to. When we started the discussion with this particular goal, I wonder if the original intent was that we were going to expand programs, and now we're only talking about expanding access. Did we change it from what you guys had done overnight to do away with the broad take a brazen effect and go after actually expanding the number of programs that we have?
Actually, I think, if I'm reading this right, I think we took it much broader to be both existing programs, you know, as you had brought up, making sure that we know about what's already out there, but that we also have a focus on developing new programs and services where they may not exist.
Okay, do you think this says that? I'm missing it if it does, just be sure.
I think that might be addressed in one of the drivers, James.
I'm good with that too. I just didn't want to throw out an idea out there and have us completely change something just because I suggested something.
No, just
else.
hold on to that
You
thought
know,
later.
Okay, so can
It
we,
wasn't my intent.
so can we scroll up and just take a look at, because there's a couple that we haven't touched on the third one, and maybe because it's perfect, maybe not. But I wanted to make sure that we had a chance to touch on every one of them and give you all an opportunity to work your magic on them. So are we protect financial and workplace security of family caregivers? Are we?
And this is Hector. I think that the concept protect has a particular connotation of sort of more like sort of preventing harm.
Mm-hmm.
Well, like the intention of goal number one is to actually improve. So I think that it does matter if we want to sort of if that's what we're trying to say, that this is all about, you know, the person doesn't get fired because has a family caregiving responsibility. That's a different issue than dealing with a goal of no, we want caregivers not to do better financially than they are doing today. And so so in that sense, I will say protect and enhance. So in that sense, again, it's beyond just simply preventing harm.
Okay, so you're suggesting that after protect we add and enhance, protect and enhance.
Mm-hmm. Yes.
What do folks think about that?
I like that.
How about the word promote?
No, I think we're protect.
I like both words. I like protect and enhance. This is Carol.
This is Diane. I like that also, the enhance.
Protect and enhance. Okay.
This is Helen. I feel like it's my job to point out that this one also is very challenging to identify existing federal policy levers or places where the federal government could currently do much here without expanded legislative authority.
That's okay.
Yeah, we agree with you.
So just a point of clarification. So even though we acknowledge this is going to be really tough, do we have a consensus from you all that you want to keep this as a goal?
We have a long time to keep working on it, so let's keep it as a goal.
And there may be, you know, recognizing the minimal to almost no policy levers that we have in the federal government, particularly around the financial piece. There are perhaps some steps that, you know, that maybe through research and identification of different practices that we could promote. So, you know, that would come from the next goal down. But yeah,
right, I think, yeah, I think you have to have something in here. I agree. I think it's challenging to do this, the financial security of caregivers. But again, this is Ben. Sorry, we without having something in the way of the financial security in this, then it doesn't feel as strong of an exercise.
Okay.
It's also possible that some of the actions are not governmental. They may be workplace settings.
Mhm.
Right.
Okay.
So,
But this is Diane. Wouldn't that be some of the financial and workplace is going to be driven by state laws? So maybe protect is hard for us to do, but promote by working with the partners, which we say in the, the last bullet. And because it might be more of there might be some federal level things, but the great majority probably is going to be more state driven.
Well, I'll push back on that. There's a lot of consumer protection issues that could be actually come up in this space from the, think about a caregiver who may have a student loan and it's facing a financial shock. There may be opportunities to work with lenders and others to come up with deferments and other similar types of things. So I will not limit right now this concept of both protection and enhancement. There is a lot that doesn't have to go through the legislative process that can be done both either by working with companies or working with agencies adjusting their own regulatory authority.
Might we want to use all three words in there: protect, promote, and enhance?
that's what I was going to suggest, because there's, I think, the opportunity for all of that in varying degrees.
My only question comes back to the SMART issue. I don't know that we can document protect, but on the other hand, security kind of is that. If we're promoting workplace security, then we would be also promoting the protection. I'm just coming back to the SMART. We can document, promote, and enhance.
Right. And maybe, as I think it was Bruce who suggested earlier, that we can always come back and revisit these goals once we begin developing, the drivers and the recommendations under them, that we may wind up having to tweak these a bit more.
Just taking a broad view, are you overall happy with the 5 goals and the general direction? And do you feel like we're missing anything? Or do you feel like these 5 capture the essence of what you'll be working on?
I'm good with them because I think we're under each one. There will be enough drivers to work with also.
Good.
Hi, this is Alan Stevens. I'm fine. I've been able to listen, but not get really on to comment. But I like the goals, and I think the wording Smith that is going on has been very good. Again, I apologize. I've been trying to keep up as best I can and trying to negotiate on 2 different computers. So I've got something now, so I apologize.
That's all right.
This is Rhonda, and I like it. But I was looking back at what's in the act, and we have dropped out the word person-centered, and I'm okay with that. I'm just raising it as an issue.
Well, but again, in the principles that we adopted yesterday as our North Star, person-centeredness would be infused throughout each of the goals. That type of an approach. Does that get at your concern, Rhonda?
Yeah, and I mean, I'm happy with the goals. I was just doing a double check.
Yeah. No, I think the principles that we adopted yesterday will be our, as Wendy refers to them, our North Star on each one of these, and we would need to ensure that everything that we do kind of adheres to those general principles. Well, what would be great to do is if we could, among the non-federal members who are on, if we could push out a poll to say, do we want to adopt these goals for now as the ones that we're going to be working from? realizing that as you really get into the meat of the work here in the coming months, that things may adjust a little bit, and we can always come back to visit that. So are we ready to take a vote among the non-federal members?
Yes.
All right, let's go ahead and push out that, wait, Lori's. Yeah, these are the non-federal council members only would be voting on this. So we've put the survey or the poll up. If you all could please respond. Are we going to adopt these? Yeah, we'll have to wordsmith. Wendy's pointing out there's some, little punctuation and grammatical things, but in general, these won't be changing for now. So give you all another minute or so to make your decision, and then we can go ahead and move on with Bruce's discussion of driver diagrams. We have 13 responses, and I think those are all of the non-feds that we have on. So let's go ahead let's go ahead and see the vote. Wow, we have 100%. Excellent. Thank you all. So this is really kind of exciting to be moving along like this and to see the progress that you all are making. We wanted to turn now to Dr. Bruce Fink, who is with the Indian Health Service, to walk us through a discussion of driver diagrams, which will hopefully provide you with enough of a grounding in how we're going to begin to add some substance under each one of those goals. So Bruce, can I turn it over to you?
Yes, thanks. But actually, I have to correct. So I'm not the acting director of the Nashville area any longer. That's now Dr. Beverly Cotton. But I still am with Indian Health Service. I serve as a senior advisor to the Office of Quality. So just okay. So I don't want to present myself as somebody I'm not. That was a role I filled in last year. So
okay.
We're going to talk through the use of a driver diagram as a tool we can use in our work here. And this should say, actually, obviously, RAISE Act a driver diagram. And this is built off of some work we did with NAPA, and that's why that title is there. We can go on to the next slide to avoid confusion. And a lot of this work is based in work that the Institute for Healthcare Improvement has done over the last 20 to plus years, around large-scale transformation efforts. And what a driver diagram is a tool. It's a tool that actually presents a logic model that provides kind of a visual display of our theory of action, of how we think we're going to accomplish something we're trying to accomplish. So in this work, we've identified a set of goals. And the question is, how do we actually get to those goals? And what the driver diagram suggests the theory that says, if we want to achieve these goals, these are the actions we're going to need to take. It is in that way, I often refer to it, and others refer to it, as an action-oriented driver diagram. So unlike more sort of researchy driver diagrams, it doesn't try to explain or show everything, every factor involved. What it does is say, if we want to achieve a goal or an aim, what do we need to do? And it does that by establishing a kind of a relationship between what we're trying to accomplish, the overall aim or the specific goals of the project, and then the drivers, the things that we can do that contribute directly to achieving those aims. And it's broken out, and we'll show you in a minute, by primary and secondary drivers, and then specific activities or tactics, strategies and tactics in the drivers. Its real value, it has a number of values, but one of the things it does is make clear and explicit how we think we're gonna get to where we want to go to, and that's really helpful, I think, in work like RAISE, where we each come to this work with our own ideas about what's necessary. we've just spent some really valuable time coming to consensus around overall goals. And this can be thought of as another way to sort of make clear what we're trying to accomplish and how we're going to try to accomplish it. I will say what a driver diagram is not is a concrete work plan, hard set. It is a work plan, but it needs to be adapted as we learn. So if we're doing work in a given driver and we're not accomplishing our goal, we should be asking ourselves if we have the driver diagram right, if we have the theory right, or if there's other actions we need to take in order to accomplish our goal. So it needs to be able to be adjusted. So next slide. So it starts with a clearly identified aim. And I think in this work, we've broken that aim out in terms of 5 goals. And then it identified the drivers that are necessary to achieve the aim. And for each goal, it would identify the key drivers. And I heard somebody earlier use the term priority. And I think it's fine to use the term priority in place of driver. You know, because when we say priority, we think this is important in order to achieve our goal, and that's actually what a driver is. It's the actions that we think are important to achieve the goal. And then it identifies the actions or interventions in each driver. And then finally, and this is really important, it identifies some measures for the drivers and the actions. Because if we have measures, and they don't have to be perfect, if we have ways of understanding whether or not we're actually doing work in the driver, then we can start to learn together about whether that work is helping us achieve our aims, our goals. So the next slide. This is a very rough diagram of kind of a template of a driver diagram, right? So you start, and in place of aim here, think goal. So we'd start with our goals for RAISE, and then we'd map out the drivers we think are important. And then the secondary drivers are thought of as, so a primary driver might, in a goal might say something like, well, we talked about outreach. So outreach actually might be a driver. And then the secondary driver will further break out what we mean by outreach. And then as we move further to the right, the actions or interventions or tactics that we think are important in outreach. So you sort of, the way to read the driver is you sort of build it from left to right, but you actually make change from right to left. You're actually doing the work on the right-hand side that is within the secondary driver that feeds the primary driver that gets us to our aim. So you sort of build it from left to right, but do the action, the work from right to left. Well, next slide. Here's another simple example, and this is out of some IHI work, and it's both helpful and sometimes a little misleading to use it. I mean, not that this particular aim would be simple in any healthcare organization, but it is much, it's much less complex than our work in RAISE. But you can see how you sort of start with a clear aim, a goal, and then you identify what are the primary drivers here that will get us to that aim. And then what are the secondary drivers that are necessary to accomplish the primary drivers? And then some very specific activities on the right that we think will be part of those secondary drivers. I'll show you another example in a moment with the next slide. Or actually in a moment, but first, again, thinking about this and asking ourselves, what can a driver diagram do? It communicates the theory of the case. It's a way to talk about what we hope to accomplish and how we hope to accomplish it. It makes clear the actions we think are necessary to achieve the aim, and I particularly like using it because for myself, personally, it helps me avoid magical thinking. And by magical thinking, it's about, it helps, by that I mean it helps us connect the dots of action. that lead to the results we're trying to achieve. So often I think we, when we're talking about things in a conceptual framing, we fail to talk specifically about how we're going to get there. And this makes explicit how we're going to get there. And finally, and really importantly for this work, I think, it'll help us understand whether we're making progress to our goal. And I think Helen can attest to this in the NAPA work. There's been great work under NAPA. It's really hard sometimes to show the progress you're making over time. And I think this, if we can map out measurement to the way we can sort of think about how we're going to do the work and then map measurement to it, it helps put into place the tools we need to show progress and tell us whether we're making progress, not just overall, but even in the specific drivers and towards the specific goals. So the next slide. We use this in the NAPA, and we grafted kind of the simple IHI driver diagram that I showed you earlier into the NAPA work. We started in the NAPA much like we're starting with RAISE, with a set of sort of goals. But then in the NAPA work, we were able to sort of map the actual activities to that work using a driver diagram. So the next slide is sort of an example of that. And I don't want to get into details here because it's different work, but it gives you an idea of how in NAPA, that this represents that the aim is the NAPA aim. The primary drivers in this case are really more equivalent to our goal statements under RAISE. And then the secondary drivers would be more akin to sort of what we think the primary drivers are under RAISE. And we can kind of think about that, and that's in part because we don't have we can sort of play around with this and see how it makes most sense. There is no right way to do a driver diagram. What it should do is communicate what we need to communicate effectively. So the next slide. And to that end, this is sort of another way, just a drill down into on the research side, sort of how this works. So you have, now I will walk through this because it's a way of implementing the driver diagram in NAPA that might apply here. So that we have the overall aim of eliminating the burden of Alzheimer's disease and related dementias. One of the primary drivers, or one of was around research. Was around actually, this in this case, I think secondary driver would be more applicable to say that's around the research driver. Then there were a set of themes identified, and specific recommendations out of the research committee, which led to a set of actions that fed into the achievement of the aim. It's a slightly different way of mapping it out, but it's intended just to show that regardless of that we can map the logic out sort of sequentially. So the next slide will be a really different way of looking at this. This may not look like it. This is actually a driver diagram also from some work at CMS around the Comprehensive Primary Care Initiative. And it starts, in this case, you read this from the inside out. The aim is around comprehensive primary care for patients and families. The primary drivers are around a set of comprehensive primary care functions, and then underneath it, some additional work drivers that have to do with support of those comprehensive primary care functions. And then around that are the secondary drivers necessary to achieve the primary. The secondary drivers that are part of the primary driver and necessary to achieve the aim. And I mentioned that I show this just to show you that there's more than one way to sort of display this and to show how it works. And the next slide, you'll see how we kind of talk about it. When we try to explain this, we map it out, we break it out this way with, again, the aim in the center, primary driver in the comprehensive primary care function, secondary drivers around that. And then there are even further out specific change concepts or strategies, and then specific tactics under those. So next slide. This is just another example of that, but we won't belabor. We'll keep going and keep going. And one more. And so that's really all. I just wanted to sort of lay that out. I think what this would take is thinking in terms of our goals, thinking about what we would use to measure in our goals, thinking about what it's going to take to achieve those goals, and mapping those out as drivers. And then either as primary drivers, and then as and secondary drivers, and then further out to the specific actions it'll take to achieve those. And then once we've done that work, thinking about, and as we do that work actually, disciplining ourselves to think about how would we measure in each of the drivers what we're accomplishing here and the actions. And in some cases, I'll just point out that measurement's never perfect, and some of the measures don't work very well, and some things we may not have measurement for, but we want to put as much measurement in as we can. Helen, you sort of walked through this with us around the NAPA work. I don't know if there's anything you can say that would sort of nuance or make clearer what I've tried to present.
Sorry, I had to unmute. No, Bruce, I think you did an excellent job. I think it sounds complicated, but I think when everyone sits down and starts to think about what has to happen for these goals to be accomplished, it moves pretty quickly. And you'll find that either you have to adjust your goal a little bit to make sure it's comprehensive enough to include everything, or that it does include everything that needs to happen. And I think it was a pretty organic process for the Alzheimer's work. And as I mentioned yesterday, it's also nice to have that to look back on, to see where your gaps are and where your holes are, and measurement, very, very important. So we don't currently have a data source on family caregivers across the lifespan in the United States. So that would be something to consider, potentially, as you consider developing your recommendations, how to build the infrastructure to track how you're doing on the national strategy.
Great, thanks. And one thing I would say to reassure folks is, this isn't something we would try to do in a meeting like this to build this out, although we would want to bring it to the meeting to get comments and reflections. This is the work of it's sort of it's in the weeds work as you sort of build out the driver diagram. The guidance needs to come from this group, and particularly the thoughts about how to achieve the goals. But I think in terms of actually doing the work, what the way to do this work is to have the input of everyone here in what the goals are and how to achieve those goals, and then to try to iterate a driver diagram that makes sense using that. So it'll be a lot of back and forth, I think, till we get an image, a driver diagram that actually shows the way we're thinking about the work collectively and makes sense to everyone.
Hi, this is Alan. This great work, and I think a great framework. Could you speak more to how how the federal members contribute to the drivers? In that, I think I mentioned this yesterday. So many of the actual outcomes or the data that will be collected will be coming through those formal sources. It seemed that they would need to be heavily engaged or strong consultants in this process. Did you find that to be helpful, or is it not necessary?
Yeah, no, absolutely. I think this is a case. So again, drawing on the NAPA experience, where as the federal members really looked to the non-federal members to provide the guidance around priorities and values and strategies. And then the federal members our job, I think, often is to sort of figure out how that actually works in the system we have, and what we think is what we can do, and where we think we have the tools to do what's asked, and other places where we can't find those tools available to us. But in some ways, the driver diagram helps focus that conversation, right? Because it focuses it on action. And then in getting to those actions, it's going to help us have those sometimes difficult conversations about what it actually means to make these changes. So I think you're exactly right about that.
So Bruce, this is Greg. So if we were to begin with a little exercise today to get the council members kind of working with the goals that we more or less came to some consensus on, is there a couple of questions under each of the goals that our council members should be thinking about answering, or concepts that they should be developing?
Yeah.
What would you throw out to them?
What I would say is, I think this is going to take some work downstream. What we could do today to start to sort of think about how to do this work is to pick one goal. Let's pick a goal, and you can pick, or somebody throw out and say which goal to pick.
Okay. So let's, should we just pick goal number 1?
Okay.
Can we put the...
So this is a great one to pick, because we actually, in this goal, and this is where my comment earlier, it'll make more sense to folks now. I think if we were gonna, this is really kind of a broad, there are a lot of broad and related concepts. There's not a single measure that's going to capture awareness, outreach, education, and access. We've identified sort of at least 4 things, right? Awareness, outreach, education, and access. And I guess they're all related. They're interlinked. That's why they're in a single goal statement. But we might want to think about that in terms of separate drivers, right? Because probably what you do, or maybe not actually. Well, let me just put this out. So we've got those 4 concepts, and then we also have health, physical well-being, emotional well-being, and financial well-being. And we have caregivers, and we have care receivers. So we have all of those dimensions in this goal, right? So what I would say is, what I would ask folks to start to think about, and let's start to map this out, is at a conceptual level, what's it going to take? What are the actions we could take that would achieve this goal? Achieve awareness, outreach, education, which achieve increased access, that would address health, as well as that would address health in the dimensions identified, and that would address caregivers and care receivers. What are some of the actions that are going to be necessary, or broad strategies that would be necessary?
Well, this is Joe, and one of the things that came up in the discussion, I think conceptually, there's programs that exist that we want to build on or raise awareness of. And then the other conceptual thing is that there's a need for new programs, or there's populations that don't have access to any of the existing programs. So that's sort of 2 conceptual ideas to see.
And I actually, as you say that, I'm going to modify my suggestion to say think broad conceptually, but also think specifically if you want to. Let's map it all, let's list it all out, and we can organize it later into the driver diagram. So let's go with, if you think broad conceptually, go for it. If you're someone who thinks really specifically program, throw those ideas out too.
So this is Helen. I'm only jumping in to get the ball rolling. One thing would be to make sure that you have providers and I want to say the healthcare system, but the providers are educated and empowered to identify caregivers and to provide them with support. So sort of like the infrastructure to do this.
And I'll throw out from an Indian health standpoint, and I think from other, that, you know, this has to be specific to cultural communities, a variety of, that has to be specific and responsive to a variety of cultures and communities.
This is Nancy Murray. I think families should have access to knowledgeable, experienced care coordinators.
That's great. I'm just going to point out that you move to more specific action, which I love, because that helps us think about this in terms of actual actions.
This is Diane. If you're going to raise the awareness, outreach, education, and access, you have to know to what. I mean, we can just say programs, but we need to identify in some systematic way what the existing programs and services are that will also help us identify what's missing.
That's great.
That's great. Other thoughts?
Go ahead.
What else did folks have in mind when we wrote this goal? Any specific actions or specific ideas?
And Bruce, this is Helen. I'll just flip it the other way. As you, as caregivers, think about this, what are the things that you would need in order to optimize your health and your well-being? You know, one thing I think of is time. So the support so that you can invest your time in taking care of yourself. What else do people need?
Caregiver assessment plans.
One thing for caregivers, especially primary caregivers, is reliable care for your family member so that you can take time for yourself.
And affordable care.
So if for example, if your family member requires nursing care, and right now most states are dealing with a nursing shortage, you know, you may be authorized for so many hours of nursing, but those hours of nursing are not being delivered. So we need reliable people who are going to come in to take care of our family member so that we can get some respite. I really think it comes back to information for caregivers because you don't know what you don't know. So caregivers need access to, you know, easy to understand information about, you know, eligibility for services, you know, what types of services are out there. I mean, it all starts with information.
this is Hector, and I just want to say that just from what we know from financial decision making, that the expectation that people will know everything and where to go to for every single program, particularly if you cross multiple domains, not just the health, but let's say psychological help and into other, and potentially even the financial aspect, that a key sort of ingredient is to identify some of those drivers, whether it's at the community level or the national level, like the elder care locator, that can serve that purpose. And so if people are directed to the trusted source that can do that for them, that is important. The expectation, again, that people will know eligibility changes, program change every year. And so again, the idea that caregivers will be on top of this is problematic. And so I think a key driver here are those intermediaries that the federal government is actually funding, from the health insurance, CHIP counseling programs, all the way to the AAAs and the ADRCs.
Hi, I was going to say something earlier and I had another problem, but I'm wondering too about the one unique resource, maybe the work that a group has just done called the Best Practices in Family Caregiving Interventions, where they looked at a deep dive into the successful evidence-based care interventions and did some of the characteristics of the interventions. But to some degree, they identify the drivers. So like if workforce is a driver, when, and as a next step, maybe Wendy, I would be happy to talk with you and Greg and maybe get David Bass to do an orientation of that project. It may be a really good starting point for drivers.
That would be great. We can definitely get with you after this and then figure out how we would get his information to the full group here.
That reminded me of this is Helen again, I'm sorry. That reminded me of our conversation earlier. So do we know, thinking about like what are the policy drivers here? So, or practice drivers? Is there something about giving ways to serve the dyad? So being able to meet the needs of a caregiver as the needs of a care recipient are met, or something along. I'm thinking about the empowering the healthcare system or healthcare provider to treat the dyad rather than just the care recipient, and so to bring the caregiver in there so that their healthcare and mental health needs are recognized. We talked about, what are the other sort of structural things that we talked about, or policy, practice, payment that we would want, that are the drivers to this, or we would need to achieve this goal?
Yeah, I agree. And I think there may even be some crossover from what we could learn in terms of, I know they looked a lot at workforce. So how do you, with these interventions that are done and created to be kind of an interdisciplinary, multiple disciplinary, engaging people and really training them to do a new set of skills. It's kind of a new part of the workforce. I think even some of that, I think, could help us examine issues around workforce, like what kind of interdisciplinary teamwork do we need for the larger issues like interaction with healthcare.
Mm-hmm.
This is James again. I also wonder about the ability to sort it out across the lifespan. Is there a way to be sure, as we determine what's available, what ages in the lifespan it's available for, so that folks in AARP don't have to start looking at stuff that's available for elementary age students and the opposite way around too.
Yeah, and the work I'm talking about is specifically for dementia, so it is narrow, and we would have to look, of course, at a lot of other different lifespan issues.
This is Diane. One of the things also, though, is for the caregivers, we need a way to, even if we identify everything for them, provide them with the information, there is a segment of that population of the caregivers who think it's wrong to accept help from whether it's their family or other, that they need to carry the burden themselves, and we need to get over that.
Wouldn't that get a bit to, I think, another piece of this goal that we haven't really touched on is the caregiver education piece and sort of all of the elements that might go along with that.
Yeah. That actually suggests a way to think about this. So in addition to there's the policy and the practice framing of this, but the other is to think, we've talked about education, outreach, and awareness. And to some degree, those three concepts are pretty related. Often education is a tool for, education and outreach are related, and certainly they raise awareness. There's sort of three very highly related concepts. And the second is access, which often is about actually access to services. So we could, if we wanted to sort of be thinking broadly as well, be thinking, what are the actions within education outreach? And I think we've identified a number of them already: education outreach and awareness. And then what are the actions within access that help us get to our goal?
This is Wendy. Would assessment of family caregivers for their own needs then, Bruce, fit into that? That's an action step?
Yeah. Okay. I think that would be an action step. That's right. And I think Helen also pointed out another potential action step, which has to do, at least conceptually, with making sure that caregivers have access to information necessary, right? The whole issue around privacy and the way that the current HIPAA regulations and privacy regulations can sometimes impede access to information. So those are two ideas, two more sort of tactics, or they're really more strategies, but that would fit within that.
A question. Some of what we were talking about really kind of hit on almost a societal or cultural view, like caregivers need help and caregivers should expect help. Is that too broad of a driver? Does that get us beyond that to that's purely social activism and change?
So that's a great question. I mean, I'm not going to answer the question, but I'm going to talk about how that question relates to the driver diagram. So if we wanted to posit that would be a major driver, right? When you talk about sort of increasing the kind of willingness of caregivers to accept help, that's a big, as you point out, it's a big concept. And so then we need to start to sort of ask ourselves, what would it take to do that? And map out further downstream what we think actually does that. Now, maybe we look at that and say, well, that's not really where we're going to put our energy. And this is where thinking of drivers as priorities is useful. And this is ideally, as we map this out, it'll help us think through where we put our actions, make those difficult decisions about what work, where we invest our resources here as a group. So I think it's a great question. And now I'd open it up to others to actually answer the questions. It's such a great question.
I think this is Nancy. I think another issue is the way, so I think Helen mentioned before policy, There's also going to have to be a shift in the way that services are funded. So many service definitions and many funding decisions are made where the person funded for services is either caregiver or the care receiver. But sometimes it does not allow for the dyad to receive services. Only one can receive the service.
And I'll add to that, when services are delivered for a dyad, services may be paid for by one agency who is technically responsible for one part of the dyad, yet the savings actually reflect more on the other part of the dyad. You know, we see this a lot in Medicaid and Medicare. You know, how if we can prevent Medicaid long-term care services, it has benefits across a lot of different payment sources. Not sure if that's somewhat similar to what you were talking to, Donna, or if it was.
I think it's another way of saying it, yes.
Okay.
It's the funding and the policy that are going to have to change.
Right. And the group that funds it may not be the most direct direct route to saving money or having better value. It may show up down the road in a different bucket.
And most of the funding, at least in the disability world, will go to the care recipient, not the caregiver.
This is Deborah. I'm wondering, since in our guiding principles, we already have the statement about fair and equitable. But when I think about access, I think about the need for the appropriate, for information available in the appropriate languages for individuals. And I think about the difference between geographic isolation and the services available in territories in rural versus urban. Do we need to specify anything about those unique, diverse caregivers if this is all underpinned with that belief of being fair and equitable?
I suspect some of that might be in the secondary drivers.
To me, this is Greg, that would almost be, when we think about access, that is, all of that seems to be bundled under the concept of access. And so it's unpacking what we mean by access and all of the things that go along with that.
So a random thought, but I wonder if our colleagues at the VA could speak to this issue, since they are often looking at a member who was in the service and then the larger family unit. And they've done so much good work in the last few years of understanding how to support the veteran through a larger social system. Maybe we're getting too much in down the road, but maybe a thought.
Greg, this is Nancy.
Yes.
Did you want us to maybe go, instead of spending so much time on one goal, did you want us to throw out some ideas for all of the goals or just stick with one goal?
Well, it was my original hope that we could maybe play around with each one of them and see sort of where the conversation takes us. And so I would be open to moving on to a couple of the other ones to see where your heads are at and what we're thinking about. Bruce, would that work as well?
I think that's great, because I think this was a really good discussion. What I would suggest here, at least to start with, and let folks think about it, is what I was sort of trying to listen and map a little bit as we were talking, and I did hear this idea that I did hear, that we talked about both. We talked about outreach and education and engagement at one level, access at another. Within the access, there's the concept of cultural and language components and also actual ensuring that the workforce is available, that there's actual true services available for access. So there's a number of issues we raised under access. I think it may be worth thinking policy and as an overarching way to think about each of these actions is what is a policy action and what is what are the policy actions necessary. But why don't we move on? I think we've got enough here that we could start to play around mapping out these ideas out into drivers and secondary drivers, even some specific actions. I think it'd be good to go on to the other goals. And now I'll leave it to you and to take us through the rest.
All right, Nancy, why don't you take it away, and we will work at this for, I would say, maybe the next half hour, 40 minutes or so, and then we should be able to get back on track with our agenda.
Okay, why don't we do this? Do you want us to spend 10 minutes on each of the next 4, and then at least we'll have something for each goal?
That would be perfect. Thank you.
Okay, good. So we have 10 minutes, team. Our second goal is up on the screen. Recognize, include, and support family caregivers as key partners in the provision of healthcare and long-term supports and services. So for me, when I think about this, there needs to be a total rethinking because right now in most service systems, family caregivers and care recipients are not at the center. In some service systems, family caregivers are almost excluded when it comes to policy decisions. So in a way, we're starting from scratch. We're like turning over who is really at the center. It's really not payers that are at the center.
So Nancy, how would you get at that? So what are all the things that would need to happen to get at that? First, the first thing I think of is change the alignment of payment, for example, or you might do something like that, or change education. What do you think the steps would be to get to something like that?
Yeah, payment certainly will drive the way certain people think about things, but I think it also needs to come from the federal government, from state government, from any body that is, setting policy, creating services. It's just a shift in the way we think in this country. I think it's AARP that puts out this number every year, the billions of dollars that family caregivers and friends provide to care for people every year. And, there's no way that, healthcare, nursing homes, whoever could possibly take care of people if there weren't for family caregivers. And I think that message needs to get out there throughout this country, that we couldn't possibly care for people with disabilities, for seniors, for anybody that needs care if it was not for family caregivers. Other countries seem to have a different way of looking at the importance of families when it comes to taking care of people who need care. We need a complete shift in this country.
This is Joan Weiss. I think that caregivers and care recipients need to be members of the interprofessional healthcare team.
This is Rhonda, and I would suggest that we have to go granular here at the very beginning. Caregivers need to be identified when they're in the system. And many healthcare systems don't know who the caregiver is. And so we can't build anything around them if we don't know they exist.
I would say most of them don't,
That's a true.
which is maybe an interesting difference in the lifespan approach, which I don't know. And so Nancy, pardon my ignorance. Is it true that with individuals who have had a lifelong need for a caregiver, that the family caregivers come in very early in life, and that partnership is built early in life, and maybe engagement as the unit is more is the foundation of the caregiving, as opposed to an older adult, the foundation for the family caregiving comes late in life when they have set up different support systems and different ways of accessing care?
Yeah, well, that's an interesting question, and I'm not sure my answer is going to answer it entirely, but you know, when it comes to people with intellectual and developmental disabilities, it's normal, if you will, for a person under the 18 to still be with their family. So the family would be taking care of that person. It's not as typical for somebody who is now 40, maybe has Down syndrome. You know, most people who are 40 now have moved out of their family's home. You know, they're not relying on their families, as opposed to maybe a 40-year-old with Down syndrome. But again, in my world, 75% of people with intellectual and developmental disabilities still live at home with their families. So it's not the typical lifespan experience that other families have. When, you know, most families launch a child sometime, you know, around the age of 18 or so. They go to work, they go to the service, they go to college. When you have a child with an intellectual or developmental disability, launching might never happen.
Yeah, thank you.
Okay, we have 5 more minutes. Let's throw something out there.
This is Joe. We talked about caregiver assessment in goal 1. I think it could go there. I think it could go here. I personally think it fits better here because we're talking about health and LSS service systems. And that's usually where like a lot of assessments are done. So whether it goes either 1 or 2, I think that's important to call out.
You know, Joe, I think that's excellent. That's an excellent point, because I think whatever service system the care recipient is in, the focus is more on the care recipient, and very rarely do social workers or caseworkers, care managers ask about the health of the caregiver and the ability of that caregiver to continue to provide care.
Yeah, this is James Murtha, and going off that, like maybe adjusting like policy procedures when it comes to privacy, so that care recipients are like offered, like, do you want to include family members or other caregivers as a part of your case, as part of your care.
Yeah.
And if so, how able is your chosen caregiver to continue to provide the care that you need?
Good point.
I think it's important to realize that when we talk about caregiver assessment, we're really talking about 2 key things. One are the caregiver's needs, but also what are their abilities and the safety for them to provide the care.
Yeah, and I will say that as we think of these, not only thinking about the fact that these people are managing appointments, potentially dealing with health issues, but most likely they're also managing financial issues for people. And at different stages in the life cycle may look very different. So you can think of an older adult who has a significant amount of savings in a 401k, et cetera. You can see both how it could be a challenge challenging for a caregiver to access that information and work potentially with a firm. But also you can also see the challenges for someone who has never invested or managed money in sort of making the right decisions about those assets.
This is Helen. I don't want to derail us, but I think about going back to this goal statement, and I know that in the conversations I've had with caregivers, some of the challenge is getting access to these services for the care recipient. I want to say for your loved one, for the care recipient. And so I wonder if by having such a specific goal, we are not potentially missing some places where caregivers have a big, big challenge, which is getting access to that care for the care recipient. And we would want to consider broadening the goals so you could think about ways to address that. I know that was something that we talked about at the first meeting and wonder if we want to raise it here.
Okay, well, at this point, we're just going to throw everybody's idea onto the list.
And what I'm noticing is that there's some overlap between the first two goals, and that's okay. That's good. Some ideas are going back and forth between the two, and that might help us think about this. I love, Helen, your suggestion that people think really specifically about actions, I think generated some really good thinking here. So I want to suggest for folks as they think about this goal and the future goals, actually to try to actually think specifically, and then we'll broaden it out to get to the conceptual later. So let's stay on the goal statement actually visually on the slide. I think it's important for us all to have, at least for me, to have this in front of me, even as you type. But any other thoughts about what it takes, specific actions that we'll need to take to recognize, include, and support family caregivers as key partners?
One of the things I would say, this is Rhonda, is we should not assume that the professionals that are working with the care recipient necessarily understand the situations of caregivers. There needs to be education for the professionals to support caregivers.
Very true.
That is such a critical statement.
Go ahead.
In this goal is, so there's one policy approach that's been taken in tribal communities, largely through the Medicaid program, of supporting family caregivers as paid caregivers for family members when an individual is eligible for formal caregiving, that to use family caregivers in that setting when there is a family member who's willing to and interested in doing that. That's another.
Yeah, I think that's a perfect segue to the third goal. I want us to, we have 10 minutes for each goal. So let's move on to the third one if we could, but I think that's a perfect segue.
Yeah.
Because one of the ways certainly of promoting financial security is to be able to pay family caregivers for the care that most of them usually provide gratis. Another issue that's out there right now, I think there's some legislation out there in the federal level of paid family leave.
You know, that's a topic I don't keep up with enough because it's so technical and so specific to policy and advocacy by different groups. I really have a hard time. I know it's so critically important, and I'm just wondering, do we need to have a special kind of task force, or have maybe some people, a couple of people, experts, do a presentation to us on that issue? Others may not feel as lost as I am, but when it comes to all of the issues around tax implications and retirement implications, I don't have that background.
Alan, this is Wendy, and I'm glad you brought that up because we can add this to the list. Just please note wherever you think we need a presentation or more information, and you're right, that's a really complicated one. We have access to an entire faculty for this project. And so we can certainly, wherever you all want, we can ask faculty members with expertise in these areas to come and speak to you all and provide any information you might need. So that's a great addition to this list, like in parens, and then we'll have that down as well.
Great, thank you.
Yeah, this is Joe. Just real quick, I think the federal level is really important, but there's also many states that, have passed paid leave policies. And then even in the private sector, some companies and corporations have implemented some sort of paid leave. So it's a multi-sector kind of recommendation or driver, I guess.
And thank you, Joe, for reminding us of that, because as we continue to build this out, it's going to be important to keep at the forefront of our minds the multi-layer or multi-levelness that the strategy is going to have to address. And so while some things may be less possible at the federal level, there may be things that could happen in the private sector that move the ball forward. And so we're going to have to also look at that, at layering that in here as well.
Well, and can we learn from some states that have implemented, good ways of doing this?
This is Wendy again, and yes, we can definitely do that. We can pull in state examples as well. So thank you for adding that also to our list here.
I think another issue when it comes to financial security for family caregivers, and again, this might be more for families of folks with long-term disability, but the absolute need for families to do future planning, including wills and special needs trusts, establishing powers of attorney, and getting that information out to people, actually beginning when your family member is quite young. It's just something families should do.
This is James. I've heard you folks over the time talk about people that are pouring their retirements into care for their family givers. And I don't even know where that goes, but somehow or the other, protection comes in how do you keep people's assets for them rather than having to pour it into family care.
And this is Helen. One thing we're thinking about is the opposite end of the age spectrum. What sort of interventions would you need for somebody who doesn't return to work after maternity leave because they have a child with a significant disability or health care need? And how would the policy interventions to keep them engaged in the workforce differ? So just throwing it out there, thinking about that population as well.
Thank you, Wendy.
This is Deborah. Also, it kind of ties into the federal leave on paid family leave, and I'm not sure if there's a crossover with the grandparents raising grandchildren group, but one of the things that we see is, especially with the opioid crisis, the you can get paid family leave to take care of a grandparent, but you can't get paid family leave or federal FMLA for to take care of a grandchild. So I don't know if there could be a policy move to include grandchildren in that list of approved relationships.
And Deborah, I'm glad you brought that up, because that does remind me of the fact that while the supporting grandparents raising grandchildren legislation is separate from this, and there's a separate grandparents advisory council, we are definitely going to have to consider the needs and concerns of grand families in the broader work that we're doing, because certainly grand families and kinship caregivers are a segment of the broader caregiving population that we're considering. So thank you for bringing that up.
Any other ideas we want to throw on the list right now for financial and workplace security?
So there is one, this is now speaking more personally because I have a nephew who has severe disability. And I think, and I'll ask the experts on the non-federal side to sort of know if this is relevant or not. But I think many families would like to contribute in an effective way to support of family members with caregiving needs, to support their, and I think about sort of tax structured opportunities to where families can, you know, over the lifetime of a child with disability, continue to help support, you know, be encouraged to support that child. So it's a little bit different than unburdening families, but it is a way to engage families who have means actually in effectively supporting their extended family members or their family members. You know, does that resonate? Is that an issue that's come up in the communities?
Yes, and actually there is a way for families of folks with various types of disabilities to do that through ABLE accounts. That's ABLE, but again, that would be, you know, education and helping families to become aware of that opportunity that exists already for them.
Yeah.
Nancy, it's not particularly able in every state either. Kentucky has a different name for it than that, so it kind of varies a little bit.
Very true, James.
Yeah,
Okay.
and James Murtha here. I just had one more. Sometimes care recipients stay off of disability and don't return to work because sometimes their states have strict policies or difficult policies that make it preventative for them to return to work and make it cost effective, which could be an area to explore to take the burden off caregivers to get care recipients back to contributing to their families.
Okay, let's move on to
Hey, Nancy, can I just say one other thing? This
sure.
is Deborah. While ABLE exists for you know, individuals identified early in life, right, and they can create an account. There right now is not such an arrangement available for family members to pitch in and help aging members, aging people who may need that assistance. So we, you know, it would be great if we could expand that type of
you know what, that's an
benefit.
that's an excellent idea, and maybe that's a policy or legislative change that could be on our list. Okay, for all the researchers in the group, I hope that you can help us with goal number 4.
Well, this is Joe, and I'll start and sort of echo something Helen brought up earlier, but most of the national surveys, particularly the health surveys that we do, but also, you know, other national surveys like the census and so forth, like they really don't identify family caregivers. So somehow working with national surveys to get questions incorporated to identify family caregivers so we can have some baseline data to be able to look over time how caregivers are actually doing in terms of health and economic well-being.
This is Hector, and I'll say that one big sort of design that needs to be promoted here, it's randomized controlled trials where we actually can sort of talk about causation in ways that other designs don't allow us to do it. And also that we do have some type of a system to help organizations that either develop services or programs to actually translate that research into practical things, and it doesn't end up just in an academic journal that no one looks at or reads.
Mm-hmm.
Would something along this line be explore the development of like research to practice toolkits and things like that, something very, very specific, so that you take the guesswork out of implementation for many smaller
or like a technical assistance team too. I have to say, even if you give someone a toolkit, you know, without the expert to sort of help navigate some of these things, and you know, so some people will be able to take the toolkit and work, others can't.
Yep.
I'm not sure how to actually put this into words. Joe, maybe you can help me. But there's a lot of research going on in the area of family support for people with disabilities. University of Pittsburgh just got a multi-million-dollar grant to do this. But a lot of times the information's not disseminated. So people like me in the field, we don't benefit from what the researchers are finding. So I think part of this is also the dissemination of good information that's coming out of research that social workers can use to help support families.
Yeah, I think you said it well.
I think, this is Rhonda, there is that step there where there is a need for assistance with translational research, which is basically taking things that have been proven and then figuring out how best to translate it and make it real in the real world. So there is a whole field in translational research, and I think that needs emphasis.
Yeah, and I would add to that, particularly on the evidence-based programs, I think most of them have been developed, you know, around older adults or people with dementia, and there is a need to sort of translate what we've learned from those to other populations, if you know, if it's suitable. So like some of the programs that are out there actually could be, you know, adapted or tried with other populations, but. So I guess the recommendation is to build the evidence base, you know, additional research and that concept of translation to other populations.
That's an excellent addition. I have experienced people looking for translations to grandparents raising grandchildren, looking for how to translate it to military folks. You know, there's a lot of ways that something that's been built around older adults. There's a lot of other populations it can focus on persons with IDD. Those are requests that I have had multiple times and really no basis to build it.
So this is Hector, and I think one big piece here is we have multiple entities doing this work. The academics are doing it, mostly funded through the federal government. You have foundations supporting nonprofits that have programs doing evaluations. And you certainly have the private sector that it's exploring its own sort of products and services. And there needs to be not just coordination, but places to share that. And I recognize that in the private sector, sometimes that involves like their own competitive advantage, but there are things that they will share and will enhance the understanding, because they may actually have data and no one of us will ever have access to.
Any other last words on research?
I was going to follow up on that last comment about, private organizations having a lot of data, and that is really true. Healthcare systems, insurance systems, there's a lot of systems that have data that are not being accessed or used to support caregivers, and it seems there needs to be a way to build some kind of relationship to really tap into that.
This is Catherine Georges. I know we're not talking about the how, but as you talk about private sector, can we think about how there's somebody talk about translational research? It means nothing if it doesn't get into the kind of medium that people can use and accept. And so I think we need to talk about how we get that into the, if you want to call it popular press or whatever, but something that would then be assisted for the people who are the caregivers. And again, I can only say, ARP's got a bulletin and all these millions of members. How do you use that medium? How do you use the medium of all these other groups like the Alzheimer's Association, et cetera, to get this information to the people?
This is Helen. One of the conversations happening on the dementia care intervention side is also how do you support the researchers in not just creating these interventions and testing them, but marketing them and getting the word out and making them translatable. So both building it on the demand side, but also the supply side, and having them go to meetings with insurers and health systems to share the information that they have.
And then Helen, this is Wendy, building on that. Once you have the evidence-based practice, then how do you scale it up?
Mm-hmm. This is Rhonda, and scaling is a big issue. And, in my own experience, what finally took hold was to go into the startup world. Helping folks get into that startup world and figuring out how to go that route would be really, really help other folks move good programs that, you build in the universities, but those aren't good places to scale them. And getting help with scaling through startup mechanisms would be wonderful.
This also speaks, I think, more broadly to the concept of in this particular area, building the business acumen of researchers to work in that area and to begin to market their interventions that have been tested.
Absolutely.
Okay, we'll move on to the last goal while we all still have some energy here. I think we're coming up with great ideas. Last goal, strengthen program administration, governance, and collaboration among stakeholders to build a society that recognizes caregivers. Okay, so that's pretty easy. Who has some primary drivers? I would just like to throw out the last couple words there, a society that recognizes caregivers. I said this earlier, and I'm going to come back to it. Unless you're part of a family where the family has experienced, a disability or chronic illness, devastating injuries from war, where family members have been family caregivers. You may not appreciate this whole issue. So I think the whole issue of family caregiving needs to be elevated in this country. At some point in most people's lives, they will rely on a caregiver. May not be a family caregiver, it may have to be a paid caregiver. But caregiving, it just needs to be elevated in this country. In other countries, it's seen as you know, just a respected, revered profession for paid caregivers, or it's what it culturally expected in many countries. But in this country, we haven't gotten there yet. So how do we strengthen program administrations and collaboration to get there?
I had an idea. This is James Murtha. Like how we're doing here, like I would like to see state by state Medicaid programs and other programs such as that, like having advisory councils with caregivers, care recipients, and, you know, possibly other people, like working together like we are now at a state level. I know California did it through those reports that we were reading, and some other states have. Why not?
James, I think that's a great idea. I would just add to that there have to be seats on the advisory council for people with, you know, disabilities and chronic health issues.
Exactly.
And family caregivers.
Yeah. As well as the people who are doing the governing too. So
Yes.
we can talk together.
But we need seats on those councils.
Oh yeah. Oh yeah.
Can I also add, Nancy, this is James, it'd be nice that if a Medicaid advisory panel met before you make a decision that's been implemented, rather than after it's been implemented and you decide it's okay.
Excellent.
In Kentucky, we seem to make it pass and then come back and ask if it's all right. Doesn't work very well. Secondly, you mentioned before about family caregiving needing to be recognized. We also have an issue here where because you do the right thing and decide to take care of your family, you can't receive the same services as those families that don't decide to take care of their family. And especially folks with intellectual and developmental disabilities.
Yes.
And I think you got to balance the playing field somehow.
How about from some of our program administrators?
So this is Greg. One of the things that would strike me is that you may have programs at the community level or at the state level that a caregiver or even a care recipient would come in contact with that may not necessarily have a need to know about the concept of caregiving or caregiver programs, but by knowing that, you truly create this no wrong door system where if you go for, let's say, an energy assistance program, you know, you could potentially be identified as a caregiver in need of other services and supports. And that's what I think when we talk about collaboration, it's truly making programs connected so that they all are kind of aware of everything about one another. And I know that's difficult, but to me, that would be more aspirational.
And this is Helen. I could see that as a place to engage, for example, the faith-based community. So that community organizations and the faith community recognize caregivers and potentially the burden that they're facing and know who to link them to get the supports that they need.
This is Wendy. We've spoken about this, but I think we might want to be really explicit here, to Bruce's point, and say, you know, that we need to have the data and tracking that's going to be necessary for the national strategy, so that we know these programs have been strengthened and that we know that we're making progress or not on the goals set out.
And when we talk about strengthening program administration, I think part of that, you know, would be, whether it's at the federal level, state level, or local level, examining our, whether it's regulations or guidance, to make sure that we're not inadvertently putting up conflicting sets of rules or guidance, that they work together and that you don't wind up negating, you know, or create potential conflicts where they wouldn't necessarily need to exist. Another area, thinking about, you know, data collection, that various programs, whether at the federal or the state level or even the local level, you know, to what extent are they already reaching family caregivers, and maybe a part of, you know, adding a couple of components to their data collection that would get at looking at the degree to which they're touching the family caregiver. You know, one of the things I think that's going to be somewhat difficult in the report that we're developing, and even in the federal inventory, is that programs may serve caregivers, but they don't really know that they are. And we're going to have a very difficult time of teasing that out. I mean, it's easy for the National Family Caregiver Support Program. We have an entire data collection protocol from states, but in other programs where their target population, caregivers are a secondary or tertiary recipient, data may be missed, and you fail then to understand the true breadth of that program's reach.
I don't know if this is even remotely doable, but it would be great if we had one department in the federal government, like we have, you know, veteran services. If we had one department in the federal government that focused on family support, because right now it's divided up, you know, maybe the Department of Health and Aging, and we're all over the place. But, you know, family support might then have more of an important place when it comes to funding and policy decisions.
It's an interesting idea. I mean, you know, ACL was founded partly to begin getting at that very issue, but you're right, you know, ACL has a number of family caregiver and family support programs, but ACF does. There may be, you know, programs within education and VA. So it is spread definitely across government. Hopefully all of this work will help to bridge some of that, at least initially.
This is Joan Weiss. I'd like to recommend that when possible, include caregivers in federal notice of funding opportunity announcements.
Okay.
As potential recipients of that funding?
As potential recipients, if they can be eligible entities, or as individuals who could, like in our case, receive education and training and participate as a recipient of the grant activities.
Okay. Mm-hmm.
And I have a thought related. It's related to the research goal, but it's also sort of in this kind of governance piece, which is that we alluded to above. We can decide where to put it, but it has to do with this notion of identifying and characterizing interventions that have a strong enough evidence base to spread. and that becomes kind of a governance question in a sense. Where do we, kind of in terms of what entity might we rely on to make that determination, or what process might we have to put that to make that determination as a way of encouraging the spread of practices and interventions.
Greg, it's a little bit after 3:30, so I think we need to turn it back over to you.
Yes, I agree, and thank you all. This has been absolutely incredible. The progress that we've made. What NASHP and ACL are going to need to do is take all of these pages of information now that we have and begin to organize it, and then we will be reaching back out to the council members to identify a strategy for moving forward in further developing this. We're not quite sure yet what that format will look like. We'll be working with the council co-chairs. Bruce will probably be tapping you for your expertise, as well as Helen, just to get us thinking on the right, down the right path, to make sure that we don't, waste energy needlessly. What we want to do now is switch to the ongoing technical assistance needs and future planning portion of the agenda. We want to hear from Dr. Pamela Nadash. I will let Wendy do the introduction and explain kind of how they're all involved.
Sure. Well, I'm very pleased to introduce Pam. Hopefully we've got Pam up on video here. And she's going to walk us through how they are going to both analyze those 1,800 plus RFI responses and get that information to you all for your deliberations, as well as conducting listening sessions across the country, which also will inform you, and again, more importantly, to hear very broadly from caregivers and others across the country. So Pam, take it away.
Okay, how do I sound? Am I echoing?
Hello.
Here, let's see.
Yes.
You know what? I think you're going to either need to mute your computer or your phone. We're hearing an echo.
Yes. All right. I'm hanging up my phone, so maybe that'll solve the problem. All right. Great. Well,
okay,
hello
great.
everyone. You can hear me better now? Yeah. Okay.
Yes.
Great. All right. Welcome everyone. Thank you for letting me present this. We're super excited about this project because I think it's going to be really, really interesting. We're also a bit intimidated by the 1,800 supposed responses we're going to have to be analyzing. So that's going to be very exciting. So let's move to the next slide. Okay. So essentially, we have been hired through a competitive bid process by NASHP to conduct this research. And the basic idea is we're here to help you, to inform you on what you're doing, and also to take guidance from you in terms of the research that we will be conducting. So the key objectives here are, as the slide says, to reach out to family caregivers and other stakeholders. We really want to get much more specific about the types of services, supports, or policy initiatives, recommendations that a broader population has. I mean, obviously, Wendy and her NASHP team are collecting lots of information about all of the existing research that's been done that speaks to policy priorities and caregiver needs, but this is going to be a unique data collection exercise that's going to involve a lot more people. And then hopefully when we move to the second stage, much more targeted assessment of caregiver needs. And the end goal, of course, is to inform the development of programs and services that can help family caregivers. And one of the key challenges, I think, of this project is that the range of family caregivers we're talking about is going to be so diverse. All right, next slide, please. All right, so there are basically 3 different components to the research. The very first one, the one you've heard a bit about today is that we're going to be analyzing the comments from the request for information in the Federal Register. Now, there are 1,800 responses. So how on earth are we going to do that? I'm not going to go into the detailed methodology because I'm sure a lot of you are not researchers and want to hear all that nitty gritty, but I'm happy to answer if anybody's really interested. But essentially, we are going to be combining the detailed reading of responses with some automated data analysis techniques that are available through qualitative analysis software. So that's the short of it. I'm not going to go into it too much, but hopefully we'll be able to identify some themes and present you with a detailed kind of analysis of those responses. And then we'll present that to you. I think the target date for presenting those findings will be sometime around the mid to late March. So we're going to have to get our socks on and start analyzing real soon. So that could be a lot of hard work. So we're going to take that to you, and hopefully you guys will digest it and make of it what you will. And then hopefully we will come out with some more focused ideas about what we want the focus groups to achieve. So we have funding for a bunch of focus groups, and these are going to be web-based focus groups. And again, I'm not so sure how much you guys want to know about the methodology, but one of the things about these focus groups is that by using the web, I think we actually get a broader spectrum of participants than in-person focus groups. This is a newer research methodology that my colleague Eileen and I have actually worked with already and found very successful in encouraging participation from a broad base of family caregivers. As you guys all well know, family caregivers are not necessarily terribly mobile. They can't leave their homes. And in this particular way, we really get to reach people who might not otherwise be able to spend, 3 or 4 hours getting to a focus group, participating in a focus group, and then going home. So I really think it's a great way of reaching people. I also have a lot of experience working with the online format. I've been teaching online for many years. So I'm very comfortable with that format. And then the third stage of the research is going to be in-person listening sessions. And there are going to be 3 of those. One of them is going to be in DC, and the 2 others will be in the Boston area. One of them will be in Spanish because we want to incorporate that population as well. And those will be conducted by our partner, Community Catalyst. Okay, and I'll talk a little bit more about those relationships in a minute. Okay, next slide. All right, so as you know, we have roughly 1,800 responses, and the questions address issues and recommendations. So we're just gonna go over those and identify key themes, and then hopefully you guys will use that to shape the subsequent stages of the research. Okay, next slide. Okay. Oh, I've already gone through all this. Sorry, I got ahead of myself. All right, there we go. Okay, so now I'm going to describe the relationships. There are a number of different parties to our project, so just so you know who's who. I am an associate professor at UMass Boston, and I work in a group with Mark Cohen, who some of you might know, under something called the LTSS Center at UMass Boston. And so we're all experienced researchers, and we specialize in LTSS policy areas. We are working very closely with ET Consulting, which is basically Eileen Tell. Any of you who have been involved in LTSS policy probably know her because she has been working in this for quite a long time. She and I have formed a really nice working relationship where we work together on on a bunch of different projects. And then the third partner in this is a group called Community Catalyst, who, again, I'm sure a lot of you are aware of as a really strong group that works to involve consumers in shaping policy. And in particular, they now have a commitment to work on LTSS topics. So this is right up their alley. They're going to be in charge of the listening sessions. They're going to identify participants and they're going to conduct them. And they've had a great deal of experience in working with consumers and consumer advocates. So all in all, it makes for a really nice bundle of expertise. So I've been very quick, but I think that's probably a good thing because you guys have really had a lot to talk about. So I think what I'll do just now is open the floor to questions. If anybody has any questions or if I haven't addressed something that you're interested in. Oh, here we go. Yes, good idea. Here's our timeline analysis. So essentially, we're going to be analyzing the Federal Register comments, as I said, pretty quickly. And then the next stage will be the focus groups. That'll probably take place over the summer. And we're thinking about summer, fall for the in-person listening sessions. And then we'll, draw everything together and present the findings. So there we go. Any questions?
So here's a question from Hector. I'm interested in how you're trying to, how you're going to be able to disentangle the using, for instance, like a program like NVivo, comments that relate to the family member, the care recipient versus the family caregiver. If let's suppose like half of those comments are about like, let's ensure the quality of the care, it's about the care recipient, and half of those are about the individual. Are you sort of reading through those first and then you're using NVivo, or I'm just trying to figure out the process.
Okay, so let me be sure I'm answering the right question. Are you concerned about being able to identify who the respondent is and analyzing the results on the basis of who the respondent is?
Or what the content, who the content is about. Like, for instance, it could be a comment about the ensuring the financial or health of the person receiving care versus like the same comment being about ensuring the financial health of the caregiver. And my experience with sometimes with tools like NVivo is that those nuances could be lost in
yeah. So we haven't done it yet, but we the hope is that what we're going to do is an iterative coding process where we have two researchers working on this. Me and my research assistant will both independently code things. And the goal, what we're going to start with is hand coding things. And so the hand coding will hopefully identify the terms that will identify, a thought as being about a care recipient or a care provider. And then once we've picked up on those terms, hopefully that will enable us to code it effectively. Now, of course, that might not work. So this is why an iterative process is really critical, because what we'll do is we'll, code, 50 responses, say, and then run it on a larger sample and then see whether that worked, and if it doesn't work, then we'll change the code and go back and run it again until, that's why I call it iterative, because it's going to have to work that way. So I hope that works.
Yeah, no, I thank you for answering that. That certainly takes care of my concern.
Yeah. I'm not saying it's going to be easy, but I think we're going to have to do a lot of back and forth like that, because I agree with you. It's going to be hard to pick out those subtleties. Any other questions? I'm sure folks have a lot of thoughts about the focus groups. I think we're going to have a lot of conversation at a later stage about, how to target those focus groups and what are the priorities in terms of data collection. So I think that's a good thing for you to start having in your mind right now. I mean, what populations are we going to target? We don't have a lot of funding for identifying very small subgroups of people because the recruitment component is always difficult. But we do want to think about, you know, how basically how to target the focus groups. So, because, you know, it's such a broad topic, caregiving. I mean, you guys just saw from your exercise there. I mean, there are so many different ways the research can go. So in order for it to be effective, we're going to have to think about how to be more specific in our aims.
Great. Thank you, Pamela. We really appreciate it. We appreciate your presentation. And this, again, is another great example of our collaboration, ACL's early on collaboration with the John A. Hartford Foundation, who funded NASHP, who then in turn used a portion of their Hartford grant to fund Pamela and her colleagues to do this work. We really think it's going to add a dimension to the work of the council, and it will add a richness to the discussion around the development of both the report, but more importantly, the national strategy. So thank you. I wanted to just move into the final portion of our meeting today, which is kind of a wrap up and kind of give you a sense of where we are with next steps. But I know that over the past couple of months of conference calls with the subcommittees, I've talked to you all about our ACL's development of our online collaboration portal that is going to be a tool that the council members, both federal and non-federal council members, as well as our stakeholder partners, will have access to. And this is going to be a tool that will allow you as individuals on the council, but also as subcommittees, to an environment to work in online that is does not involve emailing and emailing multiple copies of things. So if, for example, if a subcommittee is working on a set of recommendations or drivers in a particular area, you all can be in one environment working on one document at the same time. We really felt like it was necessary for you guys to have a safe space to work in, but also to have online discussions if you want. And so Lori Stahlbaum and I have been working very closely with our IT team here at ACL to develop this online web portal. What you're seeing here are still shots of how the site is going to be designed. We're actually moving now into the building stage of this, but it will have the home page that we just saw, which each one of our council members and as well as our partners like folks at NASHP will have access to, and it will contain file folders for each of the council members, as well as file folders for each of the subcommittees. There will be a general file area where we can have documents and things that are pertinent to everybody on the council, news and announcements. We'll eventually be able to do our meeting scheduling through there. We can conduct surveys and polls of the council members on this website. We're building it step by step. When Lori and I came up with this idea, we didn't quite realize that it was as complex as it was until our IT folks sat down with us and said, well, yeah, it's great, but we'll do this bit by bit. So, and I promise it won't be in Latin when you have it. Our IT team just puts that in there, I guess, to hold the space. So if you want to continue scrolling up, this is just a very, very quick overview of what it's going to look like. But it will have, if you can scroll up, oh yeah, no, not my face. And I just wanted to give you a quick flavor for what we're looking at here. What happened to it? Oh, okay. Okay. So we would have things for you all like an announcement section where, upcoming events could be, whether it's the next full council meeting, but also perhaps some caregiving conferences or things that you all may be speaking at or want other folks to know about. You would have the ability to have things posted here. There would be a file repository. Perhaps the most oftenly accessed files for you all would be maybe the RAISE Act legislation, the council charter, things like that that you would want to access quickly and have in one place. There'd be a discussion forum, which is going to be topic-based, and it would allow you to, one of you perhaps to pose a question and everybody else to pile on with responses, and it will all be tracked and arranged accordingly so that you guys can have discussions and exchange ideas in one place. Again, we'll have a more detailed file repository where we can upload documents that you all will be using. For example, the meeting prep guide that we created for you would be posted here as opposed to emailed to you. So I want to run through this in just a couple minutes that we have left. We'll have a discussion forum that I talked about. We aren't going to have the likes on there. We decided not to make this too Facebooky, but we will have, the ability for you to reply by subject, by discussion thread. We're really hoping that this would be a tool, like I said, that will facilitate deliberation and collaboration among the members of the council. We'll have our meetings category of this portal, which will contain, for example, every meeting that we have, all of the materials that would go with that meeting. So a prep guide, the agenda, reading materials. Our NASHP faculty would be able to provide information to you all via this portal as a way to begin sharing and looking at things to get yourselves prepped for each meeting. And then, of course, we'll have meeting, information about upcoming meetings, whether full council meetings or your subcommittee meetings, things of the like. So we're developing one for you guys, and we're also developing a similar web portal for the Grandparent Advisory Council. So we're working on two at the same time. So I just wanted to kind of briefly and quickly introduce you to this. It's still, like I said, this is just our, it's beyond a wireframe. It's really a layout, and we're actually moving into production of this, and we'll begin testing it and then testing it with you all to make sure it's usable. So I wanted to give you that.
Hey, Greg?
Yes.
Quick question. If there are new documents uploaded there, for example, in the news and announcements section, would we get some kind of a notification or an email to let us know to look there?
Yes. Yep.
Great.
Yeah. So we would have it so that it's connected. Each one of you will have different, a level of access to this, and you would all be then notified when something hits this that you may want to check it out. So more on this later, but I did want to just give you a little bit of a heads up that this is coming, and we're working on it. So just to wrap up, I want to thank you all for, I think really, Wendy and I want to say just thank you for an incredibly productive 2 days. We finalized our priority areas. We have adopted at least an initial set of goals that we're going to begin working from. And you all began to work on your drivers and some key concepts and action steps under each of those. Wendy, I think what we need to do is take everything back from these 2 days, perhaps consult with Bruce and Helen about how we structure the next steps and how we then send, again, probably a work assignment out to our subcommittees for your upcoming March meetings, give you some very clear marching orders and tasks to perform in your March subcommittee meetings, which are already scheduled. Wendy, do you want to add into that?
The only other thing I would add is that we have my colleagues and Paige and Eliza have been taking many notes over the last 2 days, as well as the fantastic ACL staff. And so we are going to type up these notes. We'll clean up a lot of the typo-y type of things and kind of clean that up, and then we'll make sure that we get that out to you as well so that you've got a document that captures all of the amazing things you were able to accomplish over just 6 hours. So again, I just want to echo what Greg has said. Thank you all, and looking forward to our March meetings.
Okay, does anybody else, any council members have any final questions, comments, concerns, anything of that nature before we adjourn for the day? Well, hearing none, I want to thank you all again. This was incredible. I'm energized and I'm excited about the progress we made. And so you will be hearing from the ACL, the RAISE Act team here at ACL about next steps coming up in just the next few weeks. So take care and have a great rest of the week, everyone. Thank you.
Bye-bye, everyone.
Thanks,
you.
everyone.
Bye-bye. Thank you.
Thank you for your leadership.